Yep.
Excellent. Well, welcome everybody to this session, Crisis Response, Who, What, and How. Crisis response systems have really been a focus and throughout all the countries of the world. I mean, here in the United States, we are passing legislation that is going to bring in a 998 number, which is basically the rival of 911. So if you actually have a crisis situation, you can call 988 and get help right from crisis services instead of going through the criminal justice system. Canada, they basically utilize the embedded co-response model, but are looking at ways to actually diversify, to bring in mental health services and give them more of a primary responsibility. In the UK, they're looking at and implementing more and more street triage. So today, what we want to do is look at the crisis response system models: who, what, and how. We will begin by looking at the three different main models. Yes, there are basically three main models, and all of the others are kind of fit into these three main models, which we'll discuss here in a second. We are going to hear from Dr. Watson, who is going to be basically providing some research on the different types of models. We are going to hear from Leah Dunbar from Canada, who is going to be talking about a very specific case study in Toronto and how there's transitioning from one model to another model. We're going to hear from Carol Speed on how to actually build the different types of partnerships needed, that if you do want to reform your crisis response system, how you can do that. And we're going to end with Thomas von Hemert, who is going to be basically talking about the training. You know, training is so important, but it's always focused on law enforcement. Tom's going to kind of share what other types of training for the other disciplines are needed. So with that, let's go ahead and jump right into it. I'm Ron Bruno. I'm the Executive Director of CIT International. I come to this presentation with over 25 years of law enforcement experience. Most of that was working with individuals in crises. A lot of it was building programs. I've been in CIT programming for the last 2 decades. So I will share some personal perspectives as we move through this presentation. Question and answers, we hope will be at the end because we have 5 panelists. We want to make sure that we do hear from each panelist. So please put your questions and answers either into the Q&A or chat, or at the end, you can raise your hand and we'd be glad to answer those questions live. So with that, let's look at the 3 different models: the law enforcement model, the embedded co-response model, and the CIT, Crisis Intervention Team model. All other models out there, or all other components, really do fit into these 3. I would challenge to find one that does not. And let's talk a little bit further on that by looking at each model, the pros and the challenges. The law enforcement model basically starts with the call to 911. From there, the call taker gathers the information and generally hands it off to a dispatcher, who then sends out law enforcement services. A police officer shows up and makes contact with the person in crisis. Usually, what the officer does is make a determination. Does the person meet statutory criteria to take the person into protective custody and transport them someplace to get further assistance? So, with this model, we basically have 3 types of dispositions. One is that if that person does meet statutory criteria, the person is generally taken to an ER, an emergency room. Some have actually advanced and do have dedicated receiving centers, but still the majority are being transported by law enforcement to emergency rooms. Another option that the officer generally has is to take the person to jail. Yes, even if the person has not committed a serious enough crime. Often law enforcement officers are tasked to make sure that the person is safe. And with that safety aspect, if they can't meet that statutory criteria to take the person into protective custody and deliver him to emergency room, or if the person voluntarily won't go, then the officer sometimes will find some type of a criminal offense that they can take them to jail, to a correction facility, because they don't feel that the person is safe to just leave them in society at that moment. And then the third option, which is unfortunate, is just to leave the person there without any true type of support, clinical support, or the help that they need. And that this type of situation often just waits until a situation arises where a second crisis comes about. So what are the benefits of the law enforcement model? Well, initial response is very cost effective. We already have law enforcement out there. Basically, it's a model that can be supported by a little bit of training and some policy, and we can have law enforcement officers respond out. Quick response time. Again, the officers are already out on the beat. They get the call, they head in that direction, and it's all by computer generally, where they can find the closest officer to respond. It's easy to implement. Again, it's only training and a little bit of policy, and you have this model up and operational. Some of the unintended consequences: it does not necessarily provide clinical benefits. As I said, we're sending a law enforcement officer out to basically just do an evaluation if the person meets that statutory criteria of danger to self or others. And if they don't, the person is generally left there without any true support. Secondary aspects are expensive. Yeah, it's inexpensive at the primary where we send the law enforcement officers out. But the secondary aspect of taking them to an ER and putting them through that system is very expensive. It may increase stigma and add to a person's trauma history. It may increase stigma and add to a person's trauma history. As I've worked with individuals in crisis, I've been told so many times they don't want to go to the hospital. It is such a grueling experience to actually, with the majority of law enforcement models, to actually be placed in handcuffs, thrown in the back of a police vehicle, taken to an ER, where basically you are taken into a room. Many times you are asked to undress and put on a gown for safety purposes, so they make sure that you're not carrying any weapons or such or could injure yourself. And then you are in that ER for hours often. And if you do meet the criteria that you need further assistance, inpatient, then in many communities, we start to look at inpatient boarding or ER boarding, where the person is actually held into the ER until they can get a bed someplace else. All of that is a very expensive situation, but it adds to that person's stigma and the trauma that they experience. It may increase criminalization and potential use of force. When I go around the country and I talk to individuals, community members, about different types of crisis situations or crisis systems, I always ask this question: raise your hand if you would say that you've ever been pulled over by a police vehicle for a minor traffic violation, that the police vehicle just pulled behind you and turned on their overheads. Most hands raise. I then say, keep your hands up if you would say that your level of anxiety, your emotional level raised just from that incident. Most hands remain raised. Yes, just the mere presence of a law enforcement officer that's focused on you can raise your anxiety, and often does. Now, that's just a traffic violation, just a minor traffic violation. Think about if you're already emotionally escalated. Think about if you're already dealing with mental health issues. Think about if you already are in a position where you are starting to feel fear, and then that officer approaches. A lot of times that can raise the fight or flight of an individual. And that's where we could possibly see the increase of the potential use of force. That's where we could see that an officer may actually think that the person is resisting or the person is fighting, and extra charges can be placed on the individual. Another thing to consider with this is that, if we didn't have law enforcement going out to every crisis situation, there will be times that, say, drug paraphernalia might be around and it wouldn't be dealt with. But oftentimes with law enforcement on scene, they're going to take action on such types of situations, and again, increase the criminalization of that individual. It may delay seeking help. As I talk to family members throughout the world about crisis situations, many times I am told that, the last thing we want to do is call law enforcement on our loved one. And so they wait until it is a true crisis situation. It's an endangering situation before they will actually reach out for assistance. The next model we want to look at is the embedded co-responder model. That is generally where we tie in behavioral health services with law enforcement services. This is a model that is very popular throughout most of the world. And let's take a look at how that works. First off, again, it starts with 911 often, where a person is in crisis or a loved one feels that somebody's in crisis, they will call 911 for that assistance. It goes into a call taker who gathers the information, kicks it over to a dispatcher who basically sends out a police vehicle. The police vehicle goes out with a certified or goes out with a clinician and a law enforcement officer to make contact. Now, this model sounds like a great model, and it actually is a good model. Let's look at the benefits. It delivers mental health care to the field. Yes, we are delivering that clinician out to the field who can realistically deliver the same type of triaging, the same type of stabilizing care that the person would get if they went into an ER to speak with a clinician. It may reduce emergency department transports. Because the person is getting the assistance that they need out in the community, often we can reduce those transports. It may increase linkage to community care because we have an experienced clinician out there whose job is to know all of the different types of community care services to link the person to. Individuals with mental illness and their families may prefer this to officer-only response, and I will allow Dr. Watson to expand on that a little bit further. So let's look at the unintended consequences. It further defines mental health crises as a law enforcement issue and expands law enforcement role. Realize that this is an actual law enforcement response. It is a law enforcement model, but it does bring in that embedded co-responder, the clinician. But it expands the role of law enforcement because we are still relying on law enforcement to basically be primary responders to crisis situations, all crisis situations. Another thing to take in consideration is that with this model, we are defining that we need law enforcement there, which may increase that stigma because the person feels like, oh my gosh, or the family feels like, oh my gosh, mental illness is a dangerous situation, and people that are in crises or have mental illness are dangerous. That's why we need armed law enforcement officers to respond to these situations. And again, it can increase a person's trauma history to actually experience this. It may allow clinical interaction to be dictated by police policy. This is important. It may allow clinical interaction to be dictated by police policy. What do I mean by that? Well, let's look at an agency. Here in the United States, a major law enforcement agency that utilizes the embedded co-response model and has really been a leader in it since the 1980s, puts out this sheet into the community about what to expect and what you need to have on hand if you are calling 911 over a crisis response situation. It's a great idea, by the way. We recommend that you do put out something like this into the community. However, again, looking at that policy issue, if you look at this one little section right here, it states, officers will detain your family member, which will include handcuffing, and is for the safety of everyone, including your family member. It does not say may, it says will include handcuffing. And as I spoke to the sergeant over this team, it is their policy that if you call law enforcement, the first thing that's going to happen before, even if the embedded co-response comes out, the person has got to be restrained in handcuffs before the clinician can actually deal with the individual. Another thing is that most embedded co-response models are secondary. They just cannot come up with enough teams of law enforcement tied in with clinicians to respond to every crisis situation. So like in this community, they will respond out when available, but the majority of the time they send law enforcement officers out, patrol officers out to go out and deal with the situation, put the person in handcuffs, make a determination whether they do need to actually bring out the specialized team. And if so, that person remains in handcuffs until this team responds out. If the team is too far away, they don't want to leave the officer sitting in the house with the person handcuffed for too long. So they will transport them to a precinct where they will be then handcuffed to a rail, waiting for that team to respond. All that is policy set up by law enforcement. Now, you may say, well, my agency would never do that. We don't do that. Well, that is true. Most agencies don't. But as police chiefs come and go, policies change. We see that all the time. This model may increase criminalization and potential use of force just as the law enforcement officer, because again, this is just an adaptation of the law enforcement model because we rely on law enforcement to be responders. And it allows avoidance to adequately fund mental health services. If mental health services can get away by placing an individual in a car to respond out, they don't have to worry about trying to develop their own system to become the primary responders to crisis situations. So now let's look at the CIT model, the third model. First, it begins with collaboration. It brings together the community members. It brings together family members of individuals that actually utilize these services. It brings together those with lived experience that utilize the services, mental health services, behavioral health care, all behavioral health care services, as well as law enforcement services, to look at their crisis response system and determine what is it that they want, what is best for their community. It continues with crisis system mapping, looking at, well, if a call comes in, where does it go? Who then is going to respond out? And if the person does need to be taken out of the community, where do they go? So let's look at the CIT model. First off, you'll see there's a blue line right down the center. That blue line basically represents the division of two systems. The two systems over on one side with the gentleman in the blue represents 911, an emergency communication center. On the other side, we have the behavioral health care system. We have a person in the gray sweater or the gray shirt that is representing a crisis line. So right here is where we really need to be looking at crisis response. This is where it begins. All we have to do is basically provide training, back it with policy, and we can build a link between 911, the criminal justice system, and the crisis line, the behavioral healthcare system. We train those dispatchers on how to basically, or the call takers on the 911, how to triage the call, make a determination whether they do need law enforcement out there right then and now. And if they don't, they can hand that off to the crisis line, do a warm handoff to the crisis line. Crisis line, of course, can do a secondary triage. And if they make a determination at any time that there is a level of danger that they need law enforcement out, they can do it back. But we need that kind of connection between these two services. We know that the majority of calls that go into an emergency communication center, 911, do not require a law enforcement response. And as we know that, we also know that 80% plus in many times, the calls that go to a crisis line can be resolved at that level. If we can resolve a lot of the crisis calls right at this level, telephonically, without ever sending somebody out in the community, would that not be the best model? Now, we're not going to resolve everything at that level. So we are going to have resources to send out. Over on the dispatch side, the 911 side, we always have the ability to send out EMS or law enforcement. But what we also want to look at is, again, putting behavioral healthcare services in the driver's seat and taking over crisis response from mental health services. The first thing we want to do is possibly do a handoff, if possible, from crisis line to a warm line. A warm line is generally staffed by a certified peer specialist. Many times a person that is in crises doesn't need urgent care, but just needs an empathetic ear. And that's where, if we build the behavioral health crisis response system on the behavioral health side, again, we can handle more and more calls there without having to send somebody out into the community. But if we do need to go out into the community, hopefully we have non-law enforcement crisis response teams that can respond out. Again, the majority of crisis calls that go into a 911 center do not require law enforcement. So what we want to do is we want to train a team of non-law enforcement personnel to go out. Now, this team is designed differently in many communities. Many times it is a clinician with the assistance of a certified peer specialist that goes out into the community. In other areas, they're utilizing medical services, an EMT or a paramedic that would respond out with the clinician. Whatever the case, whatever that makeup is, it is removing law enforcement from the equation and basically treating this as a health issue, sending out healthcare workers to deal with this health emergency. Now, the embedded co-response does have some great benefits of safety. There will be times that law enforcement does have to respond out, absolutely. So what we want to do is we want to make sure that we have a cadre of law enforcement officers in every community, not just a special team. We want a cadre of specially trained patrol officers, because that way, if an emergent situation happens, we can get an officer out there that's trained. And that's kind of where CIT comes in, is that we train that officer in how to respond out. But not only that, we train that officer on how to work with those non-law enforcement assets. And we train the non-law enforcement crisis response team on how to work with those law enforcement officers, those specially trained law enforcement officers. Because that way, just as we had that connection between 911 and crisis, we build that connection with the specially trained officer, CIT officer, and the non-law enforcement crisis responders. And realistically, they're trained so well that they act just in the exact same way that an embedded co-response can act. The difference is that the majority of the time, we're just going to send out non-law enforcement and not have to send law enforcement to go out at all. But we may have to still remove people from the community, and if so, on this side, we do have the emergency rooms. But again, let's look at behavioral healthcare taking the lead. If we can build crisis response centers, freestanding, or if we can do a triage center inside a hospital, separate from an ER, both the crisis response center or the triage center, the receiving center that's inside a hospital, is built on the living room model so that crises are handled in the least intrusive manner. And that's what this is all about. The best way to handle a crisis is to deal with it in the least intrusive manner. If we can resolve a crisis situation telephonically, we should. If we can resolve it by sending out a non-law enforcement team, we should. If we can just keep the person in the community and not take them out of the community to have to transport them someplace else for stabilization, we should. What are the benefits? It reduces calls to 911 because most of those calls, we now are retraining our communities to find out how to basically, or where they can actually get assistance without calling 911. They can call the crisis line directly for those services. It provides opportunity for crisis to be handled telephonically, again, in the least intrusive manner. It reduces transports because we, again, are handling the majority of them telephonically. And those we aren't, we are sending out non-law enforcement that can deal with the situation in the community. Even if we co-respond with law enforcement, the dedicated CIT officers with the non-law enforcement crisis response team, those are generally resolved out in the community. Very few transports need to be made. It delivers mental health care to the field and increases linkage to care the exact same way that the embedded co-response model does. It reduces contact with the criminal justice system, criminalization, and potential use of force, because we are reducing those times when law enforcement is involved in these situations. And remember, law enforcement is the gateway of the criminal justice system. It is part of the criminal justice system. It reduces stigma and potential increase in a person's trauma history. It reduces that because now we are dealing with this as a health issue. And we explain that to the person that we are dealing with. It encourages seeking help earlier. We're not calling cops on our loved one. Hey, let's just reach out to this crisis line. And it is the most effective and least intrusive manner in the lines of handling a crisis. Challenges: it often requires crisis system reform and restructuring, and it does require financial commitment to community services. That's the CIT model. So with that, I'd like to hand it over to Dr. Amy Watson so that she can now talk a little bit more about the studies and the research that have gone into the different models. Amy?
Thank you, Ron. All right, so I'm going to talk about what the research tells us about these models. Let's see if I can get. So first, we have a number of studies that have tried to look at what is the percentage of or frequency of police contact with people with serious mental illness and those experiencing crisis. And the best estimates that we have is that between 6 to 10% of all police contacts with the public involve people with serious mental illnesses. If we're looking more broadly at behavioral health type of contacts, the numbers are higher. In the US, we also know that around a third of people with serious mental illness have the police involved in their pathways to care. The data that we have on fatal police shootings suggests that at least 1 in 4 individuals fatally shot by police had a mental illness. And there's some thinking that the numbers may be higher than that. And we also know that over 1 million arrests of people with mental illness occur in the US every year. So there's been a number of studies that have looked at the experiences of people with mental illnesses in these situations, and they really support some of the things that Ron was talking about, that people that have had police involved in mental health crisis events indicate that they really feel like they, having the police there suggested that having a mental illness made them a criminal. They experience shame. They also experience stigma, particularly when police involvement made it more of a public event with lights and police cars. They also talk a lot about when they're in crisis, having the police show up really makes them feel vulnerable and frightened. We did a study in Chicago interviewing people that had had police contacts, and really the biggest theme that came out of it is that they felt really frightened. They talked about, worrying that, they were going to be killed or, be arrested, those types of things. So they really indicate that having police involved heightens their vulnerability and stress during these encounters, and that this actually can escalate the crisis that they're experiencing. It also can make it more difficult for them to really figure out how to kind of work through the crisis and get to the care that they need. Having police involved has also resulted in increasing the lack of trust in both the legal and the mental health care system for people with serious mental illnesses. We also know that system involvement exacerbates people's unmet mental health needs. It can make it more difficult for them to access services once they've become involved in the system. And once they enter the criminal legal system, they tend to stay longer than people without serious mental illnesses. They tend to stay in jail longer. They tend to serve more of their sentences if they're once they're sentenced. They also, if they're on community corrections, are more likely to have their supervision revoked for technical violations. So when looking at the research on the co-responder model, again, this kind of supports much of what Ron was saying. But the research that is out there, there's a growing body of research. Actually, the pace has accelerated quite a bit in the past 10 years. But it suggests that the co-responder model is really predominant in Canada and the UK. It's growing in popularity in Australia, and it's getting a lot of attention right now in the United States. And what research really has found is that there's a lot of variation in how this is being implemented. So, in some communities, the clinician and the officer ride together in the same car. In other communities, they arrive separately, and so they co-respond but show up separately. And still other communities, the clinician actually provides support via the telephone or via a virtual connection. There's also variation in terms of how they're actually dispatched to calls. So in some communities, co-responder teams are dispatched to hot calls. So a 911 call comes in and is identified as appropriate for the team, and they're sent as the first response. In other communities, they're dispatched as a secondary response at the request of the first responding officer, or still in other communities, these teams do follow up to police calls. Oftentimes, the availability of these teams are not 24/7. Communities just don't necessarily have the capacity and the resources to field them 24/7. And what we're seeing now, you know, consistent with what Ron said, is that there's some variation in the makeup of these co-responder teams as well, where some may involve an EMT or medic. Some of them may also include certified peer specialists. So there's been 2 systematic reviews of the co-responder team model, as well as a number of quasi-experimental and descriptive research studies. And altogether, they really suggest that this type of model is acceptable to the stakeholders on the law enforcement side, on the mental health side, and generally for people with mental illnesses and their family members. There's evidence that they improve collaboration between police and mental health. There's also some evidence that in some communities that having these teams available may reduce officers' time on scene. There's also a couple of studies that have looked at the impact on ED transports and connection to care following the call that signals that they may reduce emergency room transport. So having the clinician on scene to assess the need for that transport or not can be effective in preventing the transports that don't need to happen. And it also increases the admission rate for those who are transported. So the result is basically having the clinician there means that the people that are transported are truly the people that need to be transported. There's some evidence that these teams can reduce repeat calls for service as well, because having the clinician there can actually get people connected to care in the follow-up period. In terms of some of the qualitative work on co-responder teams, so just a couple of considerations. This is a theme that's come up actually in the CIT research as well. It's just the concern about the lack of community mental health services is really consistently noted as an issue. So fielding co-responder teams doesn't necessarily fix if there's a lack of resources to actually connect people to. So having a robust community mental health system is still really important. There's also been a few studies where people have expressed concern about including police officers in events that might be better handled with mental health only response. And this is, something that has come out in interviews with clinicians as well as with people with serious mental illness, who will talk about how they prefer having a clinician officer team to just having officers alone. But really what they prefer is not to have police involved at all. Another consideration is that there's more limited research on mental health mobile crisis, which is just clinicians and no law enforcement. But the benefits to the co-responder team seem to be similar to the benefits of mobile crisis teams in terms of reducing emergency department transports and connecting to people to care in the follow-up period. So now I'm going to talk a little bit about the research on the crisis intervention team model. And this is where my work has really focused the most. And we do have pretty robust evidence that CIT training can improve officer knowledge, their attitudes, their skills, and their self-efficacy for responding to mental health crisis calls. And this is actually from probably the largest study that has looked at this, that was led by Michael Compton in Georgia. And these were his findings, and his findings have been actually replicated in a number of other studies as well, suggesting that it's a pretty robust finding. So while we haven't had a randomized control trial that has looked at this, a number of studies have looked at the impact of CIT using quasi-experimental methods and had similar findings in terms of these officer level outcomes. In considering the impact of CIT on linkage to mental health care, so transports to emergency departments, transports to triage centers, or other types of linkage to care, we also have relatively strong evidence on CITs having a positive impact and in increasing those linkages. This article is from an early study that was done by Jennifer Teller and her colleagues in Ohio. And what they found is following the implementation of CIT, they had an increase in transports for people to the emergency room, as well as among the CIT trained officers, an increase in the percentage of those transports that were on a voluntary basis. More recently, there's been some work in Michigan led by Cheryl Kubiak and Erin Comartin. And what they found is, following CIT implementation, they saw an increase in officers taking people to a crisis triage center that was serving the county. This study also looked at the impact of CIT on officer knowledge and attitudes and self-efficacy, and they replicated the findings that Michael Compton found in his large study in Georgia. Michael Compton also did some work in Georgia, in addition to the article I showed earlier, looking at outcomes of actual calls. So looking at the impact of CIT on how calls were resolved. And there he found that the CIT officers were more likely to link people to care, and also less likely to arrest people with serious mental illness than their non-CIT counterparts. And finally, some recent work that we were just able to get published, looking at the impact of CIT in Chicago. There we found that calls that received a CIT response were more likely to be resolved with a linkage to care. We also found that if calls were pre-identified as having a mental health component, that also was associated with a greater likelihood of the person being either transported or provided with referral to care as well. Additionally, if calls occurred in people's homes, they are more likely to be resolved with a linkage to care. So there we have, while we don't, again, have a randomized controlled trial, we do have a variety of studies using different methods done in different jurisdictions that really support that CIT can increase the likelihood that calls will be resolved by linking people to care in some way. So in terms of a really important outcome is looking at use of force. And here we have some early work that Michael Compton led in Georgia, where officers were presented with a series of scenarios that increased sort of the escalation. And officers were asked about their endorsement and their perceptions of the effectiveness of uses of force at different levels of escalation. And CIT trained and non-CIT trained officers were compared. And the findings were that the CIT officers were less likely to endorse the use of force and more likely to endorse more de-escalation type skills. Additionally, some work that we did in Chicago, we found that CIT officers were less likely to use force with more escalated or more resistant subjects as well. Michael Compton's work did also find that CIT officers were more likely to indicate that their highest level of force was just verbal negotiation. So from the study that was on the slide earlier. So we have some signals that CIT has the impact that we'd like to see in terms of reducing use of force in these encounters. The issue with really looking at use of force is that it's a lower frequency event. So it's more difficult to really look at and capture statistical significance, but we have some signals that CIT can reduce use of force in these calls. So looking at the data that Michael Compton had from the two studies that he did in Georgia, he was able to capture whether the CIT officers that were involved in the study had volunteered to CIT training or if they were voluntold or mandated to CIT training. So looking at if that self-selection effect really provides a benefit. And what his findings were is across the officer level outcomes as well as the call outcomes, that self-selecting or officers volunteering to become CIT officers enhance the benefit of CIT. So it was really support for that self-selection component of the CIT model, is getting officers that are wanting to be CIT officers, providing them with the tools that really has a benefit over mandating CIT training for officers. And so finally, just there's also evidence that CIT can be adapted to low income settings. Michael Compton and his team did some work in Liberia. It was funded by the Carter Center. And what they found is when they went and did some work with the communities there to adapt the model, that they needed to adjust a little bit the specific disorders that were focused on. So they ended up focusing on substance use disorder, psychosis, PTSD, and epilepsy. They also found that they really needed to do a lot of work to develop partnerships with religious leaders in the communities to implement their program. And a concern that really came up as they were working with the officers is that they needed to include some component addressing the mental health needs of the officers. But they've done some work and really kind of demonstrating that the model can be adapted for non-US settings and really different types of settings worldwide. And so with that, I'm going to pass it off to my colleague, Leah Dunbar, to talk about work that is going on in Toronto.
Thanks so much, Amy. So again, my name is Leah Dunbar. I'm on the board of CIT International and also on the board of Coda Health here in Toronto. And I'm the project manager for the City of Toronto Mobile Crisis Intervention Team program, also known as MCIT. So what I'm going to be talking about today is providing an overview of the changing landscape of crisis response in Toronto. So we're a really large city. I'll provide a little bit of context around that. And we have a lot of crisis response programs, but we are pretty siloed and we do have a lack of a coordinated crisis response system. So we're starting to evolve right now. Our current system is changing. We're in the midst of a lot of change right now. And I'll give an overview of that for everybody. So first, I'm just going to give a little bit of an overview of Toronto. So not only are we the home of the 2019 NBA champions, the Toronto Raptors, we also are quite a large city with a lot of services. So we have over 20 hospitals in the downtown core of Toronto. We have over 60 agencies that provide community mental health programs. In our Toronto Police Service, we have almost 5,000 police officers that serve 16 different divisions across the city. And the Toronto Police Service in 2020 received over 33,000 calls to 911 for persons in crisis. So that's about 90 calls a day. Toronto is also one of the most multicultural and multiracial cities in the world. So to give a little bit of context to that, we have over 250 ethnicities and 170 languages across the Toronto region. So that makes us quite a unique city, a city that I love living in. I was born and raised here. I spent some time living overseas in Doha and in England, but I will say that Toronto has always been home. So to give a little bit more context for people who aren't sure about the size of Toronto, we do compare it to Chicago. You'll see that the populations are quite similar in size, both in the number of people and also in the square kilometers or square mileage. We're the fourth most populous city in North America, and we're the most populous city within Canada. So this is just a brief overview of some of the mobile crisis response services that we do have within the City of Toronto. First of all, we have Gerstein Crisis Center. So they have two teams that serve our downtown core with a mobile crisis response. They also do have phone lines that are available 24/7. They have a safe beds program and a lot of other programs that are available. There's a crisis outreach service specifically for seniors called COST that's run through Wood Green Community Services, which is a larger community service. We also have street outreach for the homeless population. So they're throughout the City of Toronto. They're a 24/7 service and anybody can call them whether you need help yourself or you see somebody who might be needing help. And then the program I work with is the Mobile Crisis Intervention Team program, which is a partnership between the Toronto Police Service and 6 partner hospitals in Toronto. We do have some other services that provide mobile outreach. Youthdale provides some crisis services for youth up to 16 years old. And we do have assertive community treatment teams throughout the city that will go out, not so much in a crisis response, but to keep in touch with people who do require mental health and substance use services. So across all of these services, we do have a variety of healthcare professionals. It could be nurses, occupational therapists, social workers, peer workers, for example. Not all of the services are 24/7. Some of them are, but we don't have a lot of services, mobile services that are available 24/7, except for the police. So that's where we do tend to have a lot of the calls going through to 911, and we do end up seeing that police response, whether or not that's with the mobile crisis teams or officers on their own. So when we take a look at the different models of crisis intervention that are out there, as had been discussed previously by Ron and Amy, one of the most popular ones in Canada and England is the embedded responder model. So it's a response by both police and mental health professionals in partnership. So that's where we are right now, where we're seeing the majority of calls being responded to, either police on their own or in our MCIT partnership. What we really want to do is shift the calls away to more of a response by mental health professionals or peer response teams. So we want to see mental health calls for service receiving that healthcare response. So that's sort of the transition point that we're at right now in Toronto. So just to give a little bit of an overview of what the Toronto Mobile Crisis Intervention Team program is. So we do partner a mental health registered nurse and a specially trained police officer. So the nurse is embedded in the police vehicle with the officer, and they respond to 911 calls for people who are experiencing a mental health crisis in the community. So they will go to wherever that person is. So it's been a 20-year partnership. We're entering our 21st year this year. And last year, the teams responded to 7,400 calls for service. So as Dr. Watson discussed, there have been a lot of research done and reviews of the embedded responder models, and the model does work well. We do get really positive feedback about the program, but we're only one part of a system. And we need to evolve that system to be more comprehensive crisis response that starts with the least invasive option. So embedded co-response, it's a great model to start out with within cities that are looking for a way that they can start to evolve their programs. But the programs do need to evolve in order to be truly CIT models. So when we're looking at transitioning crisis response models, when I thought about it and reflected to how we sort of got to the point here in Toronto of getting to a major transition, often there has to be a catalyst. It can be a negative event, or it can be some champions that really have reached that tipping point to make everybody understand the importance of providing health response to 911 calls for people experiencing a crisis. So you want to try to avoid that negative event. You want to try to get ahead of the system. So in Toronto, we did see, as everybody else did, we were in the middle of a global pandemic. In the US, there was the death of Mr. George Floyd, and then we saw a lot of calls for defunding the police. And then people looking at how can we evolve the crisis response model away from the police, and how we can provide a better response to people who are experiencing a crisis. So the next thing is executive commitment. This is really important. We started seeing the Mayor of Toronto and Toronto City Council that were really interested in this. And we saw interest not only at the municipal, but at the provincial and the federal levels, who were able to provide some funding and resources in order to be able to start that transition of the model. And then it's very important to co-design programs with people with experience in mental health and substance use. And this means involving people right from the beginning in design, not at the end, giving people a model to try to give a check mark and say, yes, we did check in with people. It needs to be co-designed right from the beginning with people who are going to be using the services. So if we look at some of the transition activities that are taking place in the city of Toronto right now, the first thing is we will be piloting civilian-led mobile crisis response teams. So this is being led by the city of Toronto, and there are going to be 4 pilots starting hopefully at the beginning of 2022. So those pilots will be spread across the city, and one of them will be an Indigenous-led pilot. So the city is going to be releasing RFPs, looking for community agencies who will lead these different pilots. And then they will also be working with a third-party evaluator to make sure that we have some robust evaluations of the program before it hopefully will evolve to a citywide model past the pilot stage. The next thing that we're seeing is a crisis call diversion pilot with Toronto Police Service and an anchor partner, so a mental health agency they will be working with. So they're hoping to be piloting that sometime within 2021. Again, it's important in recognizing that if a person is experiencing a mental health crisis, they should be receiving that mental health response. So adequately trained call takers are an important step in diverting those calls away from the criminal justice system to the public health sector. So that's a really important part of the transition activities that are taking place. Within our own mobile crisis intervention team program, we're seeing enhanced aftercare and follow-up response. So what we have done in our program is we've partnered with a mental health agency in Toronto to provide case management to community members that MCIT sees, and they do need to be connected to some sort of service. So we met with all of the major mental health agencies within the city, and the advice that we were given was there's not a lot of capacity in the current system. So we used our own budget to create that capacity and partner with an agency who's able to provide that case management service and hopefully provide that more appropriate care for people. So they have the case manager that they can go to instead of calling 911. And then we're seeing a lot of advocacy and input from community stakeholder groups. So for example, we have the Reach Out Response Network, which is a volunteer-led advocacy organization. So they partnered with the city of Toronto and led a ton of town halls. I think they did 16 town halls, focus groups, surveys, one-on-one interviews, and gathered all that information on what the citizens of Toronto would like to see in a civilian-led mobile crisis response team. So they gathered all that information and gave that to the city to help in designing what that new program will look like. So on the horizon, we have a lot of things that are in motion right now and are just starting and will be evolving and starting in 2021 and 2022. So we've got the city's civilian-led response teams that'll be starting next year. We have our MCIT case coordinators. We've been running that for about 1.5 years, and we're about to expand that program again. The call diversion program will be starting this year. So we're really starting to move towards a more coordinated, comprehensive, citywide crisis response system. So as I mentioned at the beginning, a lot of our programs are really siloed. So we're really trying to evolve and change the healthcare landscape, especially in mental health and crisis response and how it's organized. So we do have in Ontario, we are having a reorganization of our health system that's sort of aligning with this work. So with our Ontario health teams that are evolving, we're seeing more agencies organize, and hopefully that will help with referral pathways throughout the crisis response system, so we can have the least invasive response that people need and also have seamless transitions from system to system. We also did see some opportunities come about with COVID. So for example, there's some digital services that we're able to provide now that previously people were apprehensive about. So all of a sudden, ideas that we wanted to pilot previously, people are saying, oh yes, with COVID, we need to figure out new ways that we can evolve and innovate. So we're jumping onto those sorts of ideas as well. And also, we need to work on lowering our wait times in our hospital emergency departments. And as we know, this isn't a unique issue to Toronto, it's a global issue. But really, even more importantly, would be advocating for 24/7 mental health and substance use clinics or receiving centers. We would love to see some in Toronto. We've seen successful examples of this model throughout the US, New Zealand, and we do have one in London, Ontario that works really well. So that would be sort of the cherry on top of our evolving crisis response system here in Toronto. So that's the overview of what is happening here. So what I am going to do now is I will pass it over to Carol Speed, who is the Executive Administrator with CIT International. Thanks, everyone.
Good morning. As Leah said, thank you, Leah. My name is Carol Speed. I am coming to you from Salt Lake City, Utah. I have worked with various levels of government and all the way down to local agencies for over 20 years and have been working with crisis intervention teams since about 2013. And I get to talk to you about my favorite part of CIT. If I could, hold on. We have a pause as we jump through our slides. So relationships, partnerships. Life is based on relationships, and CIT is no different. We have advocacy, which is consumers, our family members, and they bring and add insight from those that are directly affected. Next, we have mental health. This community plays an important role. It is vital for the implementation, the development, and ongoing sustainability. They also provide treatment, education, and training. And last but not least, we have law enforcement and criminal justice agencies. From the operational and at the policy level, they are essential to the formation and the success of CIT. So if we were to sum it up, it's no wonder the first core element of CIT is partnerships. You need to build that strong foundation so that you can grow from that. Many communities have few resources. We're going to look at building and strengthening the crisis system through all of our partnerships and our relationships. And finally, we have training, which is definitely important, but it is just a component. It's not the actual whole program. And Tom's going to talk a little bit more about that in the next session. So who's in your corner? Let's think about who you would want on your steering committee. What a good structure would look like. You want strong members. You want those that have some authority. You want to be able to create a unified voice that everyone is going to be talking the same talk and heading in the same direction, strengthening each other's relationships and resources and building on that. You want to make sure that you understand each other's language. Everyone has their own set of acronyms and definitions, and we want to make sure that we're talking the same talk. You want to ensure you have the right people talking to the right audience. So if you're going to talk to a criminal justice or a court system, you want to make sure that you send somebody with authority that they're going to be able to understand, they're going to listen to, and they're going to respond to. If you send the wrong person in to talk to a certain group of individuals, you may not get the response that you're looking for. Just like a cat on a rooftop looking out over a big city, it can be so overwhelming and confusing as to what is all out there. It's a big world. We have so many assets in our community. So how do you figure out what they are, where they are, who to call? How do you access them? Let me tell you how. What if you could pull together all of your partners, all of your stakeholders, those that even would be part of your steering committee? And as you brought them together, you explored their resources, what they have to offer, how they can benefit the system, how you can build off of each other's strengths and assets. So there's various ways to do this. A couple of the ways I'm going to talk about. The first would be a crisis system review. This would be more like sitting down and doing a tabletop exercise. You're looking at what each agency or what each partner has. What are their assets? How can they be collaborated and utilized to the fullest potential? And then at the same time, you can also look at what needs you have, being able to identify those and work towards filling those needs, whether it's through other partnerships or bringing in additional funding through grants and being able to grow your program. Another way of doing it is through the sequential intercept model. Policy Research Associates developed this model, and this is more of a structured timeline through the system. So in this model, you would start at intercept 0, which is your community services. What do you currently have for the continuum of care that's available to all members of the community? Looking at your crisis lines, your shelters, your mobile crisis unit. And then as you start moving through the system, next you have intercept 1, which falls into your law enforcement, your 911 numbers. This is when they need to become involved. As you start identifying these various agencies, you're looking for your gaps in your resources and what they can offer and how the process works through the system. So next we would go into intercept 2, which talks about your initial detention, your first court appearance. This is once an individual is taken and has a charge placed on them by law enforcement. Intercept 3, we're moving forward to specialty courts. We're looking at the jail, any dispositional courts. What does that look like? How many people are there manning the jail? Are they using assessments as they enter that system? Jumping over to intercept 4, now we're over in reentry. We're talking about coming back into the community. What does that look like? Are there services in place? Are there additional resources that are being handed out to those individuals as they're leaving the jail? Is there a warm transition, a warm handoff in place that's helping them get to that first appointment? And then the last intercept is our community corrections, parole and probation. How does that work? How do they access that? Are they given a ride there, or are they just given their first appointment set up? And then that pulls us full circle right back into the community. So everything on each end of this model comes full circle, whether it's your crisis units, your homeless shelters, your food, your transportation. This just really goes into drilling it down into great detail for everything that's available. Out of both of those programs that I just talked about, you would end up creating a plan. Here you're going to identify your gaps, your opportunities, and then you create an action plan with the members that are involved in those areas. And just remember, you always want to bring in your outside members, not just someone that has the funding or somebody that works in the mental health unit, because outside partners always have something to contribute. Even the faith-based community has benefits that they can bring to the table. As you create this action plan, you are looking at short and long-term goals. You are working on breaking down your silos. You're increasing collaboration and partnerships, and you create movement. This is a living document that once you've identified and you've drilled down and fine-tuned one of the items on your action plans, you tweak it and you move forward and you keep going until you get that perfect crisis system that you're looking for. And that actually takes us full circle all the way back to having those strong relationships. And with that, short and sweet, I'm going to turn it over to Thomas. Thank you.
Good morning, everybody. I'm Tom von Hemert, and I work as the CIT coordinator for the Thomas Jefferson Area CIT program. I'm based in Charlottesville, Virginia, and I've been the coordinator since the inception of the program 15 years ago. I run the largest CIT program in Virginia, which covers over 9 jurisdictions. What's important to know about that is that it covers both urban, suburban, and rural areas, places that are quite fluent, and then also localities and counties that are really struggling with poverty issues and lack of resources. So it's a really diverse program within that. And I was a current member, I was a past member with CIT International Board. So it's great to be here. And my focus today is about training aspects, especially with law enforcement, emergency dispatchers, non-law enforcement, and crisis responders, and that, et cetera. And that means everybody. That means you, no matter what job field or job title that you have within that. I want to talk about training aspects, and I want to take it from the 30,000 level field and down to the work that we do within crisis intervention and crisis with CIT. One is my belief about trainings and about adult learning. And I have, my philosophy is this, it's 3 things. 1, what we hear, we forget, okay? As articulate, as passionate as I'm going to try to be, people are going to say, oh, what a great speaker, or, you know, he was so articulate, he was so passionate and everything else. But what was it, the information that I was trying to provide that is going to make a difference in your work, in your world, with your community? And that to me is really important. So 1, most of the times of what we say is in presentations, people forget. 2, what we see, we remember. So a lot of the PowerPoints that I have are going to have sort of visual displays. A lot of parts of the training that I do are going to be with videos or presentations where there's interaction. And that's the last and most important part. The third part is that what we participate in is what we remember, or what makes a difference in our work, in our skill set, in our knowledge. And so throughout CIT trainings and throughout any type of training that I do, whether I'm doing it for law enforcement, emergency dispatchers, non-crisis or non-law enforcement response responders, or, you know, anybody in the community, most of the presentations, most of the trainings that I try to present is going to be interactive. And so even today, whether you want it or like it or not, you're going to participate also within this presentation or this segment that I'm presenting on. So within that, just remember, like for us in our CIT training, we have a 40-hour training, and that's over 5 days, and it has over 20 different sessions. I require that any presentation, there is a interactive component that is required with the presenter, so that the audience members have to do something where they have to act or ask questions or interact. And so we're going to do that in this component itself, because it's not about the presenter, it's really about knowing your audience and making sure that you are respecting that audience's discipline and the community and the politics and the procedures that they have to work within their own communities or within their own confines. So within that, see if I can move this slide. Thank you. Okay. So again, We're going to be focusing on the law enforcement officers. We're going to be responding on emergency dispatchers and also different non-law enforcement crisis responders. That could be firefighters, could be medics, it could be mental health counselors, teachers. Again, knowing your audience and making sure that your training is appropriate within that action. So everybody in this field deals with crisis, somewhere in the crisis continuum. But my question to you is, what is the vision? What is the purpose of your training that you are going to be trying to present and you want the takeaway? And my question is, and I'm going to ask this, everybody put your hands on the keyboard and go to the chat box and ask yourselves, what is the one common denominator in this field that you're seeing right here that is consistent, that you want to make sure is the common denominator, common outcome for everyone here? Okay, what is that? If you can, again, hands on the keyboard and write what your perspective is of what you see is the common vision of your trainings. What is the common denominator of what you are going to be trying to portray or trying to make sure that they come out with that is that much better for them in their work that they need to be going back into the field for? Okay, so questions are, to me, in if we can go to the next slide, please. Okay, and that would be that it is about safety. No matter what field that you're in, law enforcement, dispatchers, firefighting, medics, mental health, teachers, any field that you are, I would argue that number one, it has to be about safety. And it has to also not just be about safety, it is safety in this order. It is always safety for the officer and the first responder. It is then next for the community members, and then it's for the person that's in crisis. And again, within your trainings, you want to be making sure that you're not teaching people how to be a police officer or how to be a dispatcher. What you're trying to do is increase their safety and have better outcomes. And within that, there's a lot of work that can be done to enhance those skills, to enhance those resources, to allow people to have better outcomes. And it can also be done with respect and dignity too. So with all that enhanced, we want to make sure that we want you to be involved within that. Okay, so and within that, any type of training that I also do is I put it back on the audience. I say, any part of this training that is not focused on your safety, about the community safety and the safety of the person that's in crisis, I want you to raise your hand or stop the training itself. So again, if that brings ownership back to the audience members to say, sure, I want to make sure that this is about how we keep people healthy and keep people safe and with respect and dignity. And again, we also provide unit evaluations at each of the presentations so that people can ask those questions. It's also important that within your training that you have somebody within that discipline that is also part of your training aspect. So just to note, I am not a sworn law enforcement officer. I am not a mental health clinician. And so during the presentations, during the trainings, I always have somebody within that field that is part of the audience. So I have my best instructors to sit in on the class. And so when there's a question to be asked, they will ask them directly. And people will ask these questions. I'll say, that's a great question. So let's ask our law enforcement person that's with us in their perspective and knowing that. Judges like to talk to judges. Doctors like to talk to doctors. And the same thing within any other field, people want to hear from their own. And so making sure that your presentation is not just the presenter, but it's also having your team being represented within that aspect. Okay, so within that, let's talk about your perspective of how you view things. So Ron, if we can go to the next slide, please. Okay, Here's a question. And again, I want, if you can, we got over 30 people in the audience here, is to participate with this on this. I'm going to ask a very simple question. On the screen, what do you see? And just give me a reply in the chat box of what do you see? And you can say anything you want. There's no wrong answer here. The one thing that I do ask, and I ask law enforcement, is not to say donut, you know, just to be a little stigmatizing to them. But again, just as to say, you know, what do you see and how do you see it? Okay. So in the chat box, I'm looking, and one person says, I see 2 circles. Okay, great. Anybody else, you know, have any views on this? I see a target. Rescue float. Excellent. Okay. Different levels of support available to people. Excellent. Other perspectives, other thoughts, other ways you think things. A dartboard. Excellent. A continuum. Right. A hole. Okay. Picture and instructions. Excellent. Fair enough. All right. So within that, I bet that everybody has a sort of a different perspective on this. Okay. A focus on a lens. Excellent. Okay. So as something as simple as 2 concentric circles of different diameters, we had a plethora of different viewpoints and perspectives. Now, and we see that. Okay. CIT or crisis intervention work, or any of your crisis work that you're dealing with, it's going to be about understanding perspective and how we communicate. And in your work, no matter what field that you're in, your vocabulary is very specific within that. And it's not just what you say, but even more importantly, is how that information is being received. So if I asked everybody, if they weren't looking at this screen, everybody draw me, somebody said, I see a hole, I see a lens, I see a target. Okay, how many people would have drawn this? One person was very specific and said, I see 2 circles. So again, if you weren't seeing this, and I asked everybody, draw me 2 circles, how many people would have drawn this exact diagram? Okay, and that's critically important in our world, that when we deal with somebody. So for law enforcement officers, when they say to somebody who might need to be taken in because they're either suicidal or homicidal or inability to care for themselves due to a lack of mental health capacity. And in Virginia, we call it an ECO, emergency custody order. And then that officer might say, listen, ma'am, I have to take you into custody. And from that officer perspective, they're trying to do the right thing. But what is that person receiving that information? I'm being taken into custody. It's like, excuse me, but oh shit, I'm being taken to jail. I'm doing something criminal. I'm doing something wrong. Again, we got to be looking at how we communicate and how we receive that information, and especially when somebody's in crisis. So again, in your work, how do you view crisis response systems? How do you view the work that you do, and how is that information being communicated? This is be honest with you, is a great way to do a introduction when you're doing any type of presentation on any topic. And it says, you're putting it back on the audience to say, listen, I want to respect and understand your viewpoint, your understanding, and everything else to that. Just be careful. I did this with my son, and I said, you know, what do you see? And he goes, oh, Dad, that's you. And I said, what do you mean? He goes, oh, Dad, that's an aerial picture of an overweight, bald white guy. And I was like, thanks. So be careful with that, with anything. But seriously, back to understanding perspectives and everything else. Take a look at say the word recidivism. Whether you're dealing with law enforcement or dispatchers or firefighters or a mental health clinician, that word has completely different definitions within that. So again, we want to make sure that everybody on your team is understanding, having a common denominator about the viewpoint and the information that you're trying to present within that. I also do a number of interactive exercises within the class, and I focus in on the issue about stigma. I write the word mental illness on the board, and I ask all the participants, and I'm not going to do it here because of time, but I say, what is your view? What is an honest viewpoint in the community about mental health and mental illness? And I say, just be honest, don't be politically correct here. And people are brutally honest, and they say crazy, loco, nuts, loony, and everything else like that. And I just write that information down as fast as I can. And I tell people, I say, thank you, that's honest. And then I write on another sheet of paper on another board the word cancer. And I say, tell me what those words are, honestly. And people say dying, sick, scared, brave, remission, terminal. And I say, and I collect all that information. And again, I thank everybody for doing that. And then we compare the words and how two medical illnesses of two that nobody wanted, nobody asked for. And again, I'm not questioning the cognitive behavior and the difference between the two, but we take a look at how those words, especially towards mental illness, are so stigmatizing. And within that, my belief is that our behavior will follow our words. And so during the training, we look at how that is being involved within that, okay? So Ron, if we can go to the next slide, okay? It is absolutely critical, again, coming back to knowing your audience. And this is what I see almost with every training, especially, to be honest with you, with law enforcement training on the first day. And you can see when people come into the training room, they're all looking for the back row nearest to the door, and they're all sort of having their arms crossed. And it's almost taking a look like, I dare you to teach me something. I dare you to come about this. And again, when we come back to the officers or to your participants in any type of training, so I do the exercise about, listen, I want to know your viewpoint, and also no ifs or buts. This training is going to be about increasing your safety. We're not teaching you how to do your job because you've already gone through that training and you're professional, you're certified within that field. But how can we increase your safety and better outcomes for the people that are in crisis and for your community members within that? So again, we want to have that. And again, it's what's wonderful to see is at the end of a training, any type of training, as in the bottom slide shows, is that the feedback that I've gotten from all the participants is saying, I wish I had this training, 20 years ago. I know we've needed this training forever. It was some of the best training that I've ever received in doing that. And that's phenomenal. So making sure that we have that. So much of our trainings that we focus in on is scenario-based training. So in the 40-hour training, we do 3 days of scenario-based training. Does anybody like to get up and and act out something? No, but again, if you're providing a safe field and you're looking at how we can increase safety and learning better skills, this is probably the best training that you can do within any type of work that you do. And again, with our scenarios, depending on the field of the participant, we want to have that scenario based in their discipline. So we have correctional officers, we've had dispatchers, we have law enforcement officers, we have probation officers, and within the scenarios, we make those scenarios, those crisis scenarios, based on that discipline, so that they are building those skill sets and within that. So within that, if we can go to the next slide, Ron, I appreciate it. Thanks. Okay. This comes full circle to what all the previous presenters said. Okay. The training is absolutely critical, but it's one component. Okay. It really comes back to what Ron and Leo were talking about. It's about the intervention of the team. Is that how are you improving your crisis response system? The training is fantastic and is absolutely needed within that. But how do you looking at coming back into your world of all the different players in that entire continuum system that Carol Speed so beautifully presented about the sequential intercept from the time somebody calls 911 to the time there's a response, and then how people are dealt with either in the criminal justice system or the mental health system or the community system, and then they come back in there. So making sure that you are putting all that together. I am really concerned that with training, especially from chiefs and sheriffs, that they want to do training and they're supportive of that, but it's sort of like it's a one and done. It's a 1 40-hour training or it's a 1 8-hour training. And they check that box and they say, okay, we're covered within that. It should never be that way. Sadly, a lot of law enforcement agencies, and some in Virginia, honestly, say that for an officer just to be qualified, that they have to go down to a shooting range and shoot at static targets and make a certain score, and that qualifies them for another year. So again, we've had officers that have gone through CIT trainings or other crisis trainings, and you want to make sure that each year that you are adding advanced trainings, continual trainings within that, because as the slide says, practice makes perfect. We want to have people get the help that they need in doing that. So within that, whether you're doing a 40-hour training or a 2-hour training for different community members, make sure, one, that it's an interactive training, that it's participatory, and two, you're taking a look at how is this advancing your crisis response system. Again, like Leo was talking about having a mobile crisis team. That's great. Again, how are we putting this training and how is it enhancing and being a part of the entire continuum, the entire system? So within that, we have a few minutes for questions. And so whether you want to put them in the chat box or go online out loud, we'd love to hear from you, because that's the most important part of this presentation, is hearing from you about your perspectives of what's working, what's not working, and how can we help and support that. So thank you for your time.
Thank you, Tom, and thanks to all the panelists. And I think that it is pretty clear that there was some overriding themes of all the different presentations. Basically, that crises should be handled in the least intrusive manner possible, that crises is a health condition and warrants to be addressed by healthcare system, unless there is some type of level of danger or some criminal concern that should bring law enforcement into the picture. So with that, let's go ahead and open it up for questions. And it looks like we have a few in the chat box. Let's see. Okay, I think most of these were answered. If anybody has any questions, if you want to throw it in the Q&A chat or raise your hand, we'd be glad to answer those.
So Inga has her hand up, and I'm going to allow them to speak right now and ask their question.
Excellent.
Thank you so much for a wonderful presentation. It's so refreshing to see that laid out so clearly, the 3 different models. So often we hear that, oh, there's not enough evidence, or you can't clearly say this or the next. It was fabulous. Thank you so much. My question is, how do you see CIT? I know it's CIT international, but how would you see it being evolving with other jurisdictions, other international setups? So where things are a little bit different, where there might be different needs. And I'm just thinking about Scotland. I know we've got a strong relationship with you, but it was just really hammered home to me today how much we need to work in partnership with yourselves, because you've learned so much from your experiences and the length that you've been doing this. So my question is probably about, you know, how could you see that you could work with other areas, or other countries more broadly, and maybe some examples of what you're already doing?
So thank you. That's a great question, Inga. And I think one of the things is kind of the foundational pieces of the model are really about identifying the stakeholders and partners to bring together, and then really building from there. And so some of the principles that are really at the core of the CIT model is stakeholder involvement, and that includes the people that we're really talking about responding to, is making sure we have people with lived experience, their family members, as well as the other system stakeholders that may be involved when there's crises, and then really looking and building from there to determine what's going to be sort of the least intrusive, best match for the community. So I think that's really a strong piece of it.
And let me go ahead and add is that CIT International is advancing its mission to actually expand into the different countries and offer more services. So for example, you know, you saw that to support a community that wants to learn a little bit more about CIT, learn more about partnerships, learn more about training. We started off by introducing a guide that really kind of breaks down crisis response systems and the best practices and how to get from one point to another point. But we are also now including that we are developing train the trainer programs. We're developing 40-hour or train the trainer on the 40-hour curriculum. We have enhanced our CIT coordinator certification so that they're a little bit more prepared to go back to a community and help build those partnerships and help develop the different types of programming necessary. So that's where CIT International might be able to assist out.
Thank you so much. Thank you.
And I see there's some comments in the chat from Jennifer about really kind of the issues of how we include service users. And I think she makes some really good points in terms of we don't just want people to just come in and tell their story. We want service users as part of the planning process. So as we're putting together steering committees in communities, we have to make sure that they are at the table from the beginning. And, you know, I think sometimes, you know, in some communities that's a little bit of an afterthought. So I think really pushing to make sure that this is something that's part of the work from the very beginning, and making sure that the voice and the perspectives of service users have weight. And we really listen to that. So I think it's a really good point that Jennifer's making. And I know that, Jennifer, you've done some great work in Toronto too, really kind of bringing that voice in and holding the other stakeholders accountable for being responsive to the voice of the people that this is impacting the most. So I think that's a really, really important point.
Next, we have a question from Debbie. I'm going to allow them to speak.
Hi, everyone. This is Debbie Plotnick from Mental Health America. Big fan of CIT, as many of you know. So I have a question regarding sort of where we are, and I love how CIT is always evolving, and I really offer great compliments on that. But about incorporating equity issues into the trainings and the partnerships, I'm sure that has really risen to the top. And I wondered if you'd talk a little bit about that, please.
Ron, did you want to take it or want me to? So I think that's a huge, huge issue. And it's a difficult issue in terms of how do we address that well. And, you know, there's a lot of ways that sort of CIT is evolving, you know, particularly in terms of really stressing the part of the model that is there to develop the rest of the crisis response system and reduce the role of police. But in terms of really starting to look at the equity piece, we really need to help programs from, again, similar to, you know, the service user perspective. When we're bringing in our partners, we need to bring in partners from the communities that are most impacted by policing. and make sure that they're at the table, so that as we're developing, as we're operating our programs, that we have people that can tell us, like, and really provide that feedback, and making sure that whatever it is that we're implementing is responsive to the needs of all portions of the community. In terms of incorporating it into training, it can be difficult. I've seen some CIT programs include, an hour on cultural awareness. Some call it implicit bias. And, I think that's an area where I think there's some room for some research too, is how do we best incorporate that into the training components of the model? And I think a really important piece is making sure that it's infused as well. So as we're going through and we're bringing in stakeholders, we're making sure that the stakeholders are representing the communities that we're serving. As we're developing scenarios, we're making sure that those scenarios are representing all aspects of the community that we're presenting. But I think we have a lot of work to do there as well. I mean, I think in this country, in the US, we have a lot of work to do that just across the board. But in terms of really making sure that CIT programs have what they need to be able to address equity issues, I think we have work to do. But I think that the core of that really starts with making sure that we're reaching out and including stakeholders from the communities that are really most affected.
And let me just add on and kind of echo what Amy was just saying about that, is that we do really take in consideration that when we certify programs throughout the country and world, we actually ask, is your steering committee representative of the community that it works in? And we grade that out. So we want to make sure that that is an issue. And as far as the training the aspects for law enforcement, there are a lot of programs that do include that inside their CIT training, but I think they're missing the boat there. That should be something that is actually provided in pre-service and continues throughout for all officers, not just those that are CIT officers or those that are working specialized units to respond out.
I'm going to add one factor is be really careful when you do these types of trainings. We've had a number of trainings being presented, and be honest with you, a lot of the command staff are doing it as a checkbox, and they're looking at it as the quantity of it and not the quality of it. And I've had more officers that have said, to be honest with you, it was more stigmatizing. It did more damage than the intention of that. So please vet the training and the trainer before you bring somebody in, because I've seen it go south really fast. And I could not agree more with Ron that yes, it needs to be part of the training, but overall, that should be an ongoing aspect of the entire administration and not just focused in within CIT. Too much of outside forces are trying to throw everything that they can within the CIT training. They're trying more demands and everything else. And we've lost our focus about crisis and the focus on mental health and mental illness. So just that would be my 2 cents.
I think also the other issue I see is as we push for really having non-law enforcement responses to crisis, I think one of the things that we'll have to pay a lot of attention to is how we're making decisions on what the appropriate responder is to a crisis event, and that we're not introducing bias in how we're assessing risk and oversending police to some communities and not others. So I think there's a lot that as we are, I think, in a point of opportunity to really adjust and really push more of this back to non-law enforcement responders, that we have to be very cognizant and really watch our data, watch the experience of our communities to make sure that we're not actually increasing inequities.
So we have another question in the Q&A that I'm going to put up on the screen. Actually, sorry, I can't. So I'll read it out loud for everybody. It is from Isa, and it is, do you think there might be the danger that training so many law enforcement officers with CIT, you do get/keep more law enforcement responses, while in the beginning of the presentation, it was emphasized that a response without law enforcement involved was most preferred. And then the follow-up would be, wouldn't you want to focus CIT on other professionals than law enforcement, considering a shortage of mental health nurses / workers?
That's a great question. I'm glad that was asked so that we can clarify that. So we know that for a fact that law enforcement is always going to have a role to play in crisis response, that we just cannot remove law enforcement. So the idea with CIT is that we have a cadre of specially trained, self-selected and pre-screened officers who receive this additional training to respond out only when it's warranted by a level of danger. So that is what we're looking at for the CIT officers. And as Tom was talking about, we now need to make sure that we are expanding training, not CIT training, because that really is geared to law enforcement, but we need de-escalation training and how to be able to recognize that the person's dealing with somebody that's emotionally escalated, regardless of the cause actually, and how to reduce that level of emotional encounter so that the person opens up and becomes has a better ability to be reasonable and to be able to communicate so that that way the situation can be resolved. We also want to train non-law enforcement assets on how to recognize level of danger, and if necessary, train them on how to disengage, back out, and at that time they can contact a CIT officer who has the skill set to handle a more dangerous situation, to come in and handle that situation. I hope I answered that. Does anybody else have anything to add to that?
I actually just want to add, that is a really great question, is, the danger of improving law enforcement's ability to respond is that it could sort of let the rest of the system off the hook. And that's not the intention. But we do have some workforce capacity issues on the mental health side. So really thinking about how do we prepare our workforce so that we have folks that are able to, and out there and prepared to provide this response. And also, as Ron indicated, that people that are trained and experienced and know how to assess situations. So, when they need to bring in law enforcement, they can, and if you have a CIT program and a partnership with law enforcement, then there are some smooth ways of partnering when you have to, but also being able to handle situations that, right now law enforcement in many places is handling, but really could be much better handled by non-law enforcement professionals.
Rory, any other hands raised?
Nope, I was giving just a minute in between, but that seems to be all the questions for today.
Excellent. So again, I just want to thank the panelists for joining me on this presentation. Rory, thank you very much for your leadership on this, and I want to thank everybody that attended. We are at CIT International. We stand by ready to offer technical assistance. If you have questions about anything, please feel free to give us a call. You can also download a free copy of our guide. I did upload it for this presentation. I'm not sure exactly how to access that, but you can go to our site at www.citinternational.org and download a free copy of the CIT Best Practice Guide to Community Response to Crises. So with that, again, thank you, everybody, and thank you for those attending. Have a great day and enjoy the conference.
Thank you.